Happy Wednesday afternoon. Hi. Welcome, everyone. Thank you for being here. Hi. Thank you all of you for joining us on this Wednesday afternoon for another PCNA webinar. While we're, as always, we'll just give people, I was just saying I'm not very patient. We'll give people a few minutes to join and then we'll get going. But while we're waiting, if you can please introduce yourself and your role and where you are in the chat. That is, could you please do that? Because it's just so exciting always to see where people are joining us from. And I can guess the great thing about these webinars is that people come over and over again. So a lot of the people I know now, which is lovely. Who's going to be first? You can see.
Hello.
Oh, hi.
Hi, my name is NC. I'm working as a registered nurse for San Hospital. And today is my first day to join this seminar, and I'm somehow new to the Australia as a registered nurse. I was working as a pediatric oncology nurse back to my country for more than 11 years. But yeah, I'm started working with adult with oncology in oncology at the moment. And so happy to join to your team. Thank you.
Thank you. So, and Mesh, tell me again where you are working.
At the moment, I'm working in Sydney Adventist Hospital. I'm in oncology, hematology, and palliative care, end of life care.
Okay.
Yeah.
Thank you.
Thank you. Nice to meet you.
You too. Jess has said, hi, Jess. Jess has said, joining from Chile, Melbourne at Monash Hospital. Hi, Jess. Who else is there? I'm going to start calling people out. You got one more minute. I know Gloria's there. Ruth. There's Gloria. Hi, Gloria. Hi, Gloria. Gloria's from Sydney. Thank you very much. And she's the CNC. And Katie. I know Katie's a grad nurse now, aren't you, Katie? Ruth and Anne and Emily and Robert Town. So welcome. We might get started. So welcome everyone officially to another Wednesday afternoon PCNA webinar. This one is really exciting because I think we're covering a topic that can be very confusing. And I think I've done a lot of education on advanced care planning, but I still don't feel clear about it. So I'm hoping that today with Kylie and Sam, we are going to make a little bit of headway in terms of some of the confusing bits of advanced care planning. So before we start, I'll just do an acknowledgement country. Now, someone hasn't got themselves on mute, and if you haven't got yourself on mute, pop yourself on mute. There we go. So at PCNA, we acknowledge that we live and we work on sacred lands of the First Nations people of Australia. Each person who's joining us today joins from a different location and therefore different lands of First Nations Australians. And I'm joining you from the Larrakia lands of the Larrakia people. PCNA stand in solidarity with First Nations people as they strive to overcome the impacts of colonisation and dispossession and the ongoing effects on their health and well-being. We honour, we admire and we respect Aboriginal and Torres Strait Islander people and who represent the oldest continuing culture in the world. So thank you very much. So thank you very much, all of you, for joining us. A bit of housekeeping before we start. Put your mics on mute, and if you can, I know some people will be at work. If you can, pop your camera on, because it just helps us to wave, but also just to see that we're talking to real live people. So as I said, we'll now introduce our speakers. So we're really lucky to have today to speak on advanced care planning, two speakers, Kylie and Sam, who bring a national lens and also a state and on the ground in hospital lens. So I'm just going to tell you a little bit about each of them. So Kylie is a registered nurse with a Master of Nursing. Her clinical background is in cancer and hematological settings, and she has a passion for holistic and person-led care. She currently works at Advanced Care Planning and is at Advanced Care Planning Australia and is involved in learning experiences and teaching the broader community about advanced care planning. And Sam, can you wave for us? There's Sam. Sam is a clinical nurse consultant with over 30 years nursing experience and is currently the advanced care planning lead at Eastern Health. And her role involves supporting patients and families and carers with advanced care planning conversations at hospitals and in the community. So welcome, Sam and Kylie, and thank you very, very much for your time. So the way today will run will be that I'm going to throw to Kylie, and Kylie's going to give us like the broader beginnings of what is advanced care planning and why it's important and how to start the conversation. And then we're going to have some questions, and then we're going to throw to Sam, who's going to give us a case scenario to kind of bring this into a real world context. Just the last thing to say before we get going is that as they are talking, pop questions in the chat because if you pop them in the chat, then as soon as there's a break, I will ask them for you. So without any more delay, Kylie, thank you very much for being here, and you can go for it.
There you go. Thanks a lot, Sarah. That's coming through? Brilliant.
Yep. Beautiful.
Excellent. All right. Well, thank you very much, everyone, and thank you for the welcome here today. I just wanted to give a bit of an update for those who don't know Advanced Care Planning Australia. We are a federally funded program operating as the national voice of advanced care planning, and we have activity across 3 different levels. So we engage directly with the community to promote awareness and provide the national advisory line, which I'll also say that health professionals are also able to access if they've got any questions about advanced care planning. We also support the health and aged care workforce through education, resources and advice, really to operationalise advanced care planning. And then at a systems level, we're driving policy, advocacy and research activities in this space. Underpinning advanced care planning is a legal process. So the presentation is for the purposes of sharing information in relation to advanced care planning, and information today will be provided is in general in nature, and people really should seek appropriate professional advice about their specific circumstances. Reference in this presentation will be to the overarching advanced care planning processes and documents, acknowledging that throughout Australia there are different laws and processes in every state and territory. So let's get started. What is advanced care planning? Really, it's a process that considers future healthcare. And it's also person-led, meaning it's the person's choices that are central to any conversations and documentation. And it's for all ages, not just older people and when you're ready for palliative care, although that's important, it's at any stage of age or health. And it's really about understanding and sharing your personal values, life goals and preferences regarding that future healthcare. Advanced care planning can sometimes centre on medical treatment interventions, but many times it's other things that people consider important, and we'll touch on those soon. But ultimately then, the goal of advanced care planning is to align the person's healthcare that they receive with those preferences for care, if there becomes a time when they can't communicate or make decisions. And this might be at a time close to someone's passing as they become more unwell, or it may be due to an accident or a short-term illness and the person then recovers. It might be at this stage also good to clarify what advanced care planning isn't. And whilst both advanced care planning and voluntary assisted dying may involve a person's choices regarding medical treatment and care, they are quite different. So VAD involves a person in the late stages of an advanced disease taking a substance prescribed by a doctor that will bring about their death at a time that they choose. It may be an option for those who satisfy legal eligibility criteria, but it can only be accessed and enacted by a person who can make and communicate decisions. Advanced care directives can only be enacted and only come into action when the person actually loses capacity. So that's an important distinction to make. So if a person doesn't speak to anyone about their wishes and record their preferences or instructions, and they become seriously ill or injured and can't communicate those preferences or make treatment decision makers, doctors will make treatment decisions based on their assessment of the person's best interests. They may talk to people who are not who the person would have chosen to consent to those medical treatments. This might include treatments that the person would not want at all. And really, none of us knows what will happen in the future or can predict what might happen with our health. Advanced care planning really is beneficial for everyone. It can support the person to make some of those decisions about healthcare now so that their wishes and preferences are known into the future, giving that peace of mind, allowing their voice to continue. It helps to ensure that the care that they receive is actually what they want and really an extension of that self-determination. It can improve ongoing and end-of-life care and reduce unnecessary transfers to acute care and unwanted treatment if that's what the person desires. And importantly, research tells us that family and carers of people who have done advanced care planning have less anxiety, depression, stress, and are more satisfied with the care. They can be more confident if they do take on the role of substitute decision maker to make those decisions, knowing what the person wants. So in advanced care planning, we often say it's never too early, but it can be too late to do advanced care planning. And it is particularly important if you actually have specific values, beliefs, or preferences which might influence treatment decisions. Some examples might include people of Jehovah's Witness faith who have very specific beliefs around use of blood products. For Aboriginal and Torres Strait Islander people, ties to country may be important and may influence decision-making at end of life, where care is delivered, ceremonies, inclusion of traditional medicines, say. For the LGBTIQ+ community members, it may be about ensuring chosen family are recognised as substitute decision makers. And it's really these early discussions that can really support healthcare that affirms that intersection between sexuality, gender, ethnicity, culture, and faith, supporting that respect for connections between loved ones, relations, family of choice, family of origin, for example. So I'd like you just to consider this question for a moment that's on the slide. Is it too late for Barry, with moderate dementia, to start having a conversation about advanced care planning? Oh, Sarah, I can see a grimace there. The correct answer is actually no. It's not too late for advanced care planning conversations. Now, it would have been great if Barry had got his affairs in order before his function deteriorated, but really a diagnosis of dementia does not automatically remove capacity to make choices within advanced care planning. Remembering that decision-making capacity is situation specific. Not every decision is going forward is dependent on whether or not that person has capacity applies to that one decision. It's not for every decision moving forward. And despite having dementia or any other condition, people should be presumed to have capacity unless there is reason to suggest otherwise. And individuals with dementia may be able to provide meaningful input and contribute effectively to some decisions that do still affect them, even with advanced dementia. So certainly something to just consider. And really, an important part of this sort of conversation is really around supported decision making. And this reinforces that capacity is not black and white. It's so important as we see more people with dementia in our health and aged care services. Supported decision making is a set of concepts and principles. It involves any type of help or assistance which is provided for people with a disability or a cognitive impairment to meet their communication needs. And it promotes that real equal accessibility. So think about mobility ramps. It applies those same constructs to the architecture of decision making, ensuring that the person's will and preferences are central to decision making instead of that real best interest determination. And I think supported decision making is really a way of ensuring that voice of the vulnerable person is included throughout the advanced care planning process. And I've mentioned a number of times, it is a process. And it's a process that someone may dip in and out of. It isn't necessarily linear. It doesn't rely on every step being undertaken in an order. And it isn't just about the documents being completed. It really respecting that person's readiness and going at their own pace. Parts of the process, though, do include thinking about what is important for the person, talking to trusted friends, family and healthcare providers, recording wishes if they want to in formal documents, and sharing these to make them available if and when they're needed. And the person can revisit these, each part of the process, and they can change their mind and review and update previous conversations or written documentation. So we'll just take a moment to touch on a couple of these parts of the process. When we're talking about thinking, it's about values, beliefs and preferences around future healthcare, and to really support the person to identify what are health outcomes that are acceptable to you. And really to work out what's important, a person might consider past experiences of healthcare, their current health, future health, and what does quality of life mean to that person. We often recommend that people speak to their GP or other health professionals. Now, I'm going to bring Sam into the conversation now. And in particular, how do you approach these conversations to get people to explore their values and preferences? And in particular, how to express spiritual and cultural needs? This can be a lot to consider, and these are sometimes challenging conversations.
Oh, thank you. Thanks, Kylie. Hi, everyone, and thanks for the opportunity to be here. It's a very privilege to be here and with the wisdom in the room. So one of the things that I think in health, what's really how I approach it in clinical practice is one of the things that it's really about, simple questions regarding, how are you feeling today? And just, is there anything on your mind that I could help with? And I think one of the things that I've learned from that is to actually, before you can start really talking about advanced care planning and introducing it, my experience is that you have to have some sort of rapport and respect and show respect to the person. And one of the things about showing respect, and as you said, Kylie, is about cultural and spiritual needs. So one of the things is when I ask, I've also, first of all, are you okay to speak with me today? Is now a good time? And which I know is something that's very, very important in hospitals, because often it's not a good time, because might need to go to the toilet, might need to go for surgery, might need to do something else. So it's really a simple thing, but clarifying that straight away. And then also probably once with that is, how are you feeling today? And the reason why I'm doing that is I want to know whether they're on sedation, whether they is there any other issues that are happening. But I then also will always ask, before we want to speak, is there anything I need to be respectful of culturally or spiritually? Because that's so important as we care for you. So I simply ask that question, and I'm guided by the patient or their family.
That's a really nice way to frame it.
Yeah, Sam, can I ask you what happens? Oh, yeah, I'll ask Sam. So what do you think happens, or maybe Kylie can answer this question. what happens if you ask someone to, you bring up you build rapport and you ask someone's permission, you do all the right things, and you bring up the topic of advanced care planning and they point blank refuse? What do you think, Sam or Kylie? Maybe Kylie can answer this one. What do you think? What do you
Shall
say?
I start, Sam? I'll start, Sam, and you can jump in if you think I add anything else. I think it's really acknowledging those feelings of the person, and because this is challenging and these are tender conversations. And then if it's appropriate, depending on the context of what else has happened in that conversation, perhaps asking an open-ended question to, in a gentle and curious way, explore what might be sitting behind that. And I think reinforcing exactly what Sam had said, these conversations do take trust. So looking at trying perhaps to build that trust. And this doesn't have to be a one and done conversation. This can be something that you do build on. And then at further opportunities, perhaps deepen the conversation when you're able. And I think you also do need to respect readiness and listen if the person no longer wants to have that conversation, but always leave that door open so that you can perhaps return to this. And sometimes don't just go straight for the jugular of talking about a medical treatment decision. Start gently. And I think, Sam, you mentioned, what does a good day look like for you? What is important to you? Start gently.
And the other thing, in addition to everything that Kylie said, the other thing I would say, if someone says, no, I don't want to talk about advanced care planning, and I'll say, oh, that's absolutely fine. And I say, is it okay if I just tell you that a lot of time people think that advanced care planning is about finances? That's not why I'm here today. And, it's about what's important to you so we can look after you if you become unwell.
That's right.
And
it
that's,
kind of, isn't it? Yeah. Maybe using some terms, like, as you say, kind of using terms that they understand too, right?
Yeah. And if you're talking to an Indigenous, you might say, if you get crook, it's really important. And the other thing I would say is, I also say, look, because we also work in the community, and I always say to people, well, if you change your mind, here's a bit of information if you'd like it, and just let the nurses on the ward know that you have some questions, or ask them, because we're a team. And I think that's always that, or and certainly say that, and I always add this, and I think this is really important, and I'm like, you're in control of this.
I like that.
Because I think one of the things with being in hospital is you're not in control of many things, but with future planning, they're in control of that, and I think that's a really good thing because it's empowering.
Yeah, I really love that. I guess my other question, it kind of segues from what you have just said, Sam, which is, you can kind of say, look, if you want to come, if you want to do it, you can speak to the nurses. Or I guess my question is, in a clinical team, who do you think is the best person to do the advanced care planning with the patient? Is there a best person, or what do you think?
Oh, that's a great question. Look, ultimately, I think the patient kind of intuitively will ask who they feel comfortable with. And then what I say is that they'll choose who that will be, whether it will be, and more often than not, I would say the nurses have the most direct contact, but it sometimes even might actually be the cleaners, particularly if they're waiting around. So the non-clinical staff, and they're so having that sort of camaraderie or team approach, because then if the patient comes to you and wants to talk about it and you're not sure, you can just say, well, I can get that information for you, but this is really important. And then you start the process. I think that's where, you'd want the cleaner to come to you. I think it's about who they feel confident in, and ultimately it's also as well for the individual that is not sure or doesn't feel confident, they just link to their colleagues as well and gain that skill. I think it's a lot about feeling that sometimes we can feel nervous that they're going to say something that we're not going to be comfortable with, but they may not.
Yeah, Look, and I think that's it. It's about these types of presentations are great because we all become familiar with the broader terms of advanced care planning, and you don't need to have like a one and done approach and feel like you have to solve it for the patient and know all of it from doing one webinar. But you know the terms, and you can say, look, that sounds really important. Why don't I find someone who can help us do that for you? We'll have more conversations.
Yeah, and it might be social worker, allied health, speech pathologist, depending on, if someone has difficulty swallowing or having that test, is really a time where they feel quite vulnerable and might raise about, I may not be able to eat. What's that going to look like for me? So again, it's that team approach.
Shall I just continue, Sarah, and then we'll get to the case presentation? I've only just got a couple more slides. So I guess another really important thing to think about is who it is that the person trusts to make health decisions for me. So we've sort of had those thinking about what is important in terms of my health, but if I can't speak for myself, who is it that actually is going to be making those health decisions on your behalf if you're not able to? And really, the important question is, am I confident that they will know what I actually want? So it's a really important role and something that I think as healthcare providers, we can also support people to consider. When I was talking earlier, we talked about, sometimes it's medical treatment interventions, but really sometimes it's some other things. And I just wanted to reinforce, sometimes it is many other things. And we're hearing a lot more around the fact that people want to specify who they want at their bedside and to participate in their personal care. Having that pet close by, what music they want. So we may also at that point want to consider those cultural and beliefs and actually include those in any conversations and potentially documentations. And we know that whilst these aren't legally binding choices, they are really important to consider and to guide that future healthcare when someone loses capacity. So we heard from Sam about some approaches that she uses for conversations to get people thinking about their values, but it's not always easy. And there are some free Australian resources that I just wanted to highlight that can help you to consider some of these important questions and choices that perhaps just people haven't thought of. And really it's about creating that picture of what quality of life means. The Palliative Care Australian Discussion Starter are sets of workbooks and cards that support individual or group reflection. And I can't talk about them enough. They're brilliant. The cards are great. There's specifically sets for older people and for Aboriginal and Torres Strait Islander people. You or patients can order these directly from the Palliative Care Australia website for free. So I definitely recommend that. And My Values is an online resource. It's a set of specifically constructed statements that are designed to help people identify and then communicate their wishes. And you can create your own values profile in relation to life, death, and medical interventions. And that just might help with some of those, that thinking. We do then want to empower people to talk to their loved ones and also to talk to their healthcare team, and putting some of those values and preferences into spoken words so they can prepare the substitute decision maker and really have those really meaningful conversations with health professionals. And this conversation starter template might just help people find those words. And this is available on the Advanced Care Planning Australia website as well. And we've really talked a little bit about some of these things, but I just wanted to touch on briefly some of those key principles underpinning conversations in this context. It must be led by that person and be voluntary. And we say invite, don't insist, but I think, Sam, when we've had this conversation, you really talk about asking permission. And I think you used the words earlier, is this a good time? Can we talk about this? So really seeking that permission to get the person's engagement. Reinforcing again that we respect that readiness. This isn't a one and done conversation. Plant the seeds, return to the conversation in the future, and use those gentle, open-ended questions perhaps to encourage that sharing and exploration and build that trust. And really consider that continuity of these conversations. Sam mentioned there's a big team of people that can be involved in these conversations and support the person. And really, all health and aged care professionals can recognise and respond to these cues. So document to share that information and reduce duplication and allow that building on previous discussions. And really, when discussing advanced care planning, the communication approach should be focused on being empathetic, non-judgmental, and really patient. And key qualities of this communication style include compassion and attention, sensitivity, being gentle, curious, and humble. And these qualities really do create that atmosphere of trust and openness, encouraging that open, honest communication. And a lot of that we've actually embedded in a lot of our education training, and it's come from the work of Catherine Mannix. So I do recommend, if you've got the opportunity, to look at some of her work as well. She's brilliant. I will just leave you with a final thought around communication, and this was from our community member, Judith Leeson. And she said in a most beautiful way, "I welcome resources to assist people in the planning process, but it is the empathetic communication and deep listening which will ultimately reflect the choices of the individual." So I thought that was beautiful.
Thanks, Kylie. I think there are so many take homes from what you said. I wrote so much down. But one of them, actually, the thing that stands out to me really is about and Sam alluded to it too, about creating the right environment for these conversations, right? And I guess in the community, we have maybe a little bit an easier time having an environment that's very patient-centered. And I guess I have a question for you. What happens in an acute setting where maybe these, and this is probably a Sam question because this is where you work, where these conversations have been left to a really late period, at a late stage, and perhaps, you know, there's a focus on treatment, yet we know that these conversations need to happen. How do you take that environment, and do you think these things need to happen over time? What do you think, Sam?
Yeah, no, they're really. I think one of the things, you know, one of the things, when we get a referral for a patient in the acute, we know it's noisy environment. There's not many single rooms, but what we'll always look at first is the patient's how many times they've been admitted over the last 6 months or a year. If they've had multiple presentations to ED, particularly thinking of COPD, or if they're an oncology patient, you know, they've been in and out of the hospital many, many times. And one of the things is when we get the referral to come and see them, it may well be at that point, this is the only place where the person feels able to have a conversation. They choose a location, and sometimes home is not the right place for them. You know, you might think it would be, but it's not, because they've got other life things going on. So one of the things is that we still, you know, I know the curtains aren't very wide, but we still will draw the curtain. We'll sit close to the person if they're in bed or if they're sitting out. Sometimes we will literally if we can, we'll go to a family meeting room. Anywhere where we can create a bit of space is great, but we work with what we have in the acute and subacute hospitals, you know. And I think one of the things is that patients hear things all day long. They hear lots of things. So I think if they're ready to have a conversation, it's really important that we don't avoid the cues.
Yeah, I think that's it, isn't it? Just responding to that question or the cue, and then the best you can with the environment. You know, not making an excuse of, oh, it's a busy ED, I can't have this conversation. It's like, no, actually, this is something that the person is kind of indicating that where they want to be, what I'm their person they want to speak to.
Yeah, and if going back to well, we always check how many times we've been in hospital, because you know that's also, they may know the staff on the ward really well, or they may not, depending if they've moved around a lot in the sites. But one of the things that you know, I can see you in hospital recently. You know, what was it like when you were home? And you know, how do you feel about being here? Most people say they don't like it. They don't like the food. They don't like the noise. But occasionally people say, I feel safer here because I struggle to breathe at home. So it's really about that, just like it's that listening. and probing gently to uncover. And I think, and then we have a chat about, you know, what's happening. There's a lot of grief and loss with chronic illness. And I think one of the things we often will ask patients is there anything you're worried about? And what surprises me all the time is they're often not worried about themselves. They're worried about their family, or they're worried about not being able to drive, worried about their pets.
And Sam, I wonder, because I know that you've got such depth of experience. I wonder if you would be able to share, it might be the right time now to share your case study, and the key learnings and key messages from that case study. So we might hand over to you to talk about that now, if that's okay.
Yep, definitely. And
raise my hand, my virtual hand, when we've got time for questions, okay?
perfect. So I'll go through this fairly quickly, but I really want to focus on a couple of things. So we had a referral from one of the oncology wards for an 82-year-old male. He had metastatic prostate cancer with stage 3 colorectal cancer. He had a history of hemicolectomy and a long-term IDC. And he actually had asked for some advanced care planning information on admission to one of the oncology nurses. He was alert and orientated. We checked the system. He'd already appointed his daughter as his medical treatment decision maker. So one of the things that happens frequently in hospital, we'll go to the ward and the patient might be asleep. We let them sleep. We come back, you know, that's really important. So I think one of the things is that would say, and this is that team approach, because he was asleep, we gave some information to the caring nurse. When he woke up, he said, oh, they've left this for you and they're going to come back. And again, it's that building of respect. So we came back, and when we had a conversation about what was important to him. So when it comes to talking about quality of life and values, I think people struggle with what is their value, because it's such an open, big thing to say. So we ask, you know, what's important to you? And sometimes people say, oh, my family. Or they might go through and say, well, actually, what's happening for me at the moment? And I'll just quote from what the patient said to us. I've been told by the doctors I have months rather than years, and that there are no further treatment options available. The most important thing to me is my wife is not burdened with making decisions for me at the end. And he said, and I asked, and that Weeks said that. And then I asked him, what are you, and you might think, well, this is a strange question, because one of the things that I think is really important in these conversations is leaving space and being quiet. And I asked him, is there anything else that you're worried about in your future? And he said, I have no future, though I am worried about that I might have possible bone pain. And so he'd made the decision that he didn't want to be resuscitated. He was willing for palliative care. He'd said he'd rather die in hospital. He didn't want to be resuscitated. And we drafted the directive. The directive was signed by the oncology doctor, or an oncologist. And then he said, please, can you come back and talk to my daughter and my wife? Because my wife will struggle with this. So we came back, and what the wife struggled with was him no longer wanting to be resuscitated. She felt that was something he should still want. And one of the things, and it was my colleague actually as well that was there, that had explained to the wife, even being resuscitated doesn't take the cancer away. The cancer is still there. And his wife went, oh, of course, I get it now. He's had enough of that. And so spending that extra 15 minutes with the family helped him understand that was his wish. I actually went back and had a look up the history. He actually died in April, and I can't see, it looks like he must have died at home, because there's no notes of or a death certificate yet scanned through. So even though sometimes people have a preferred place of death, it doesn't always happen, or their preferred place of death changes. So I guess one of the things, the key messages for this for us is that the timing is when of these conversations, it's really important if the patient requests information that we respond to that and we work together. And we know our colleagues really well. We complement the caring team, and we also want to help support them to speak to their family. And I think one of the things that with this patient, he'd been thinking about his thoughts and wishes for many, many months. And well, what we realize is when patients have chronic illness or are incredibly unwell, it's really hard to go to the GP to finalize your directive. It's hard to go and, so sometimes the only place they can do it is actually in hospital. So I think what the learnings are is that we engage and we chase down the treating teams and many outliers. So that's something that we do. So I think one of the learnings of this study is that it was a team approach, and that he was supported. And so that's one of the case studies.
Sam, I really love that as an example of how important these conversations are, because there was a mismatch between what the patient thought and wanted and the family. And without these kind of facilitated, supported conversations, there's maybe a gap, but even a chasm of missing communication. Really, really important information. I guess I wondered, Kylie and Sam, if you would mind me getting a bit really pragmatic. One thing I still struggle with is the different terms. So I guess particularly the things that I struggle with is, okay, so we've got advanced care planning, but there's also the term of an advanced care directive. There's also a values directive, is that right? I get lost, and I guess I wondered if one of you would be able to, as simply as possible, outline what documents there are, and then what you need to, or is that too difficult a question?
I can jump in from a national perspective and say that, yes, it is too hard to give you a very simple answer. But an advanced care directive is the catch-all terminology that we do use for those formal documents that each of the state and territories do have. And yes, they are called different documents in each state and territory. So in Northern Territory, it's an advanced personal plan. Yeah. Okay. So, pardon?
I said thank you. That's where I'm living. Yeah.
Oh, of course. So yeah, that is a difficult one. You do really need to become familiar with the documents that are in your state and territory. That is that's a key thing. Advanced care planning, I think the catchphrase, we're using that as in terms of the process. That's the process that we're talking about, advanced care planning. And it includes all of those different elements, thinking, talking, recording, across the whole spectrum.
Sorry, can I just add in there? Sorry, just quickly. So one of the things that I would say, and one of the things that's missed a lot with advanced care planning, is that so the directive is the golden number one, because it's a legislative document called different things in different states, but only the person with decision-making capacity can make it for themselves. But a lot of times people will be uncertain, may not want to put things down on paper, but they have a lot of conversations with the hospital staff about their thoughts and wishes and preferences for care. And a documented discussion in the medical record will actually also be counted as something that can identify. So it's a verbal, documented discussion, because many people, I think the term is oral. So many people will have conversations with their family, with their medical decision maker about their thoughts and wishes. And they're the things we like that will be asked. What did Sam ever talk? I'm using me as Sam. Don't know if there's any other Sams online, but did Sam ever mention anything about this sort of situation? Has she ever talked about her views on life and death? And so I think that's, if there's a directive, that's fantastic. If there's a plan written down, which is a non-statutory form, which could be an aged care, advanced care plan. There's so many names, aren't there, Kylie, of different things. But it also can be a documented discussion in the patient's medical record that would inform their care decisions.
All right, that's good to know. So, but I guess I hear what you're saying. I hear that it's different in every state. But these documents that are different in every state, are there normally two parts to it, like the kind of the treatment bit, the resuscitation bit, and then the values bit, or are they all different?
It does depend on the state. There are some states that do have two separate documents, but essentially what you're talking about is, medical instructions that a person can make decisions upon and document those instructions. And then there's also values and preferences that they can also make statements around. And the legal weight depends on what a person is actually asking. So if it's a values and preferences around their choice of where to stay, have care, those sorts of things, what quality of life means. These are not legally binding elements, but they do guide care. I think that's the important thing to look at here. What is actually legally binding? And that's sort of the difference between values and instructional parts of documents.
And I'm just going to jump in there and say it will depend on your legislation in your state. So to go against a patient's values is actually you can't. For us to go against someone's values is also very serious. So a values directive in Victoria, there's two types in the one form, but the values directive is often more clinically helpful than the instructional refusal or consent to treatment at a future time, because at a future time when they lose decision-making capacity, what they've consented to or refused may not be clinically indicated. So example, if you've got someone with kidney disease and they say, I consent to dialysis if I need it. If they collapse, have a fall, but their kidney function is fine, we're not going to give them dialysis because it's not clinically indicated. Does that make sense?
It does.
So yeah, so that's why sometimes I think the values is really can help inform the communication. The instructional where it's so powerful, and like Kylie said, is for Jehovah's Witness or for someone that's absolutely refusing a treatment in any circumstance. So someone might be, I've had patients in their 90s, or the youngest person I've helped has been 19. But in the 90s, she wrote, "What's wrong with me in my major health condition?" She went, everything's wrong with me. I'm 95.
Oh,
And they don't resuscitate me because I'm 95, And so, so it does vary.
So Sam, so given every state is different, where do people who are listening go to find out what the documents are for their state? Is there, I think there's a website, isn't there? Is that right, Kylie?
Yeah, I might just flick to that right now. I think the best place is actually come to our Advanced Care Planning Australia website. There is a spot there that you can actually go to create your plan, have a look at the state information. It's a summary on the Advanced Care Planning Australia website, but it will also link out to the state documents as well, and any further information from the jurisdictions. And if you haven't seen it, the QUT End of Life Law for Clinicians website is excellent, and it also breaks things down into state by state, the issues around capacity in each state and territory, advanced directives in each state and territory, those sorts of things. So definitely worth having a look at those two sites for sure.
Thank you. I guess I'm going to ask one more question, then I'm going to throw it out to the group. So if you're listening, just add a question in and you can be next. I guess one of the things that I picked up in, I think it was Kylie mentioned this, around dementia and advanced care planning. Now, I know this it makes me sound like I'm a very, very simple person, but it was actually a bit of a surprise to me that when you have dementia, that you can still be doing an advanced care plan. Now, I don't know why that was a surprise to me, but it was. I guess, could you talk more about that? Why?
So just to clarify the difference between doing an advanced care plan and being part of the advanced care planning process. So they can still have those conversations. They can still contribute in a meaningful way to some choices. For a person to, and I think Sam said this earlier, to actually complete an advanced care directive, they do have to have capacity. And when we're talking about that, yes, everyone, all adults should be presumed to have capacity. And capacity, we're talking about the ability to understand information, appreciation of the relevance of that information to the situation, being able to reason risks and so forth, and being able to express that choice. So there is a formal process to assess capacity in jurisdictions. So I'm not going to go into that, but that is the essentials around capacity. But I think the key part is when we think about advanced care planning, it's not just all about that document. The conversations are just as important. And there may be opportunities to continue to include that person on that journey and not just defer to a substitute decision maker to make all of those decisions. So we're really keeping that person in the center of all of that right the way through. I think that's the most important part, and that's the key messages there that I wanted to share.
I love that. I like that. I think if we could have a take home, really, is that this doesn't stop, right? As long as you can be communicating your preferences, they are important. That's beautiful. And I've actually got a question for you both here, and actually it's directed to Sam. Jess says, Sam, have you ever had to advocate for a patient with a documented advanced care directive whose treatment is not in line with the stated values?
Great question. And I would say yes.
Yes.
And I think one of the things is real challenging in practice is when the timing of when an advanced care directive is enacted. Now, we talk about when the person loses decision-making capacity, but sometimes that can fluctuate. And I think it's really important we'll say this is the time to enact their wishes. They've lost capacity. They've been really clear about what they've said and their values. And this is time where we've got to respect that. I think one of the things that I struggle with medical staff, sometimes they really struggle with that. And also families. So yeah, and I think it's this is now the time it's enacted. So to give you an example where it can be challenging, so someone, say a person's had a fall in aged care, they didn't, in their advanced care plan, it said they didn't want to come to hospital. What is best if it's worded an extra bit, I don't want to go to hospital unless the care can't be provided here, because we have a duty of care if someone's had a fall with a fracture to get them assessed. And so I know they've had a fall with a fracture, but they've actually still got capacity. So their advanced care plan didn't come into enactment. But if you've got someone who's lost decision-making capacity with dementia, on a good day, and depending if it's global or if it's Alzheimer's or what's going on a good day, they'll express their likes and dislikes very clearly. And I think if ever in doubt, if you've ever got a patient, delirium is difficult. Delirium is so difficult. And I think there's a stat I read in research that 30% of all patients admitted to hospital will have delirium within the first 48 hours. And you can have terminal delirium, as you would know as well. So I think, so one of the things is, I think it's really important that we read what's in the person's plan, their directive, and say, does this apply now? And this is whether we will withdraw, withhold, or if they've consented to a treatment that's not clinically indicated, then we need to explain to the next of kin why we are not providing that, because it's really going to cause harm. So that's why, so I think the communication of how to enact them and use them is equally as important as what's written. Yeah.
Thanks, Sam. Did that answer your question, Jess?
Do you want me to talk?
Yeah, that'd be great.
Hello. Yeah, Sam, I totally agree. And I've been working in the acute area from community for the last year, and it's been quite distressing at times seeing people coming in from aged care who have an advanced care directive saying that they don't, if they had an infection or something, They wouldn't want to return to hospital, and seeing these people coming into hospital. So that's difficult. But I suppose the situation I was talking about with the delirium was particularly difficult. It was a very difficult circumstance where the man had probably had an underlying cognitive decline over time, had been in aged care for just a little while, had come in with a new cancer, had become incredibly delirious, was under a surgical team, and he was just on the conveyor belt of treatment. And it was only after I'd seen him and sort of said, oh, this man actually has an advanced care directive that says that if he was in no way did he have capacity. And it was very clear that if he had compromised function, physical function or cognitive function, that he would find that to be completely not for him. So that was difficult, and with the surgical team in particular, they're very, very one-track minded in terms of, we think we can fix this. And he died, unfortunately. He died in hospital. But it was just a shame that and it took a lot for us and the medical team to say, we actually have this advanced care directive and we need to be listening to it. But it did take a lot they've just kind of ignored the whole issue. And it was difficult for me to work out, where is the accountability for health professionals to need to listen to that advanced care directive when somebody doesn't have capacity and it's quite clearly stated what their values are. How do we escalate that? What's the process there? Because it is people do the advanced care directives for a reason, thinking that they will be enacted, but felt a little bit lost, just not quite knowing how to manage that situation when it just was kind of, everybody was writing in the notes that we need a family meeting and we need to be responding to this advanced care directive, but it was just kind of moved. It wasn't really paid attention to for a fair while.
Yeah, I see Kylie's got her hand up, so I'll let Kylie answer before I make a comment. Yeah.
Oh, just saying on just that note, there are avenues in every state and territory to escalate clinical concerns. Obviously, we prefer to have good communication and work within the health service, but there are those jurisdictional points that people can escalate any concerns around that. I think one of the things you mentioned around the transfer from aged care, a person having a advanced care directive, we also do have to recognise that sometimes in aged care, the care workers it's not within their scope of practice to actually recognise and act upon these, and that people need to understand that. And I guess this is probably a good point to just raise that topic of the goals of care or other documentation that may support people's wishes as well. So we were talking about what is the difference between a goals of care document, and really that is a clinician-led document that can support health professionals then to perhaps not do resuscitation and give them those protections in terms of clinical decision making. But that's certainly something to consider that might, and I know in Victoria, I think it is, Sam, you've actually got some of those in aged care. There are some goals of care documents that support that activity as well.
There is, and I think, Jess, I'm mindful of the time, but Jess, good faith always applies. But what I actually kind of think also I think you're in Monash, aren't you? You said it was chilly, not Monash, or Melbourne is chilly. What I'd also say is, I think when I'm talking to surgeons, and I would say, look, you're at risk of causing medical assault because the patient has done this. And if you actually would like to have a look at the guideline for the hospital around medical consent, that will clarify it for you. So I just want to protect you and protect the patient. And that's probably what I hit with. Is that all right?
Yeah.
Is that okay? Yeah,
I think, Sam, sometimes language needs to get a little bit more serious, doesn't it? I just wanted also to add there that Meg, who has just added the REACH program in Victoria, enables clinical review for any reason and encourages review of the current carer plan. Yeah, look, some hospitals definitely have avenues like REACH to escalate concerns. So I am conscious of time. We could be talking for another hour, I think. But Kylie has got this slide up, and I imagine that is a conclusion slide there?
Yeah, just
Right.
really a summary slide. I thought that might be helpful, Sarah, just to reinforce that this is voluntary. Ongoing conversations are important, led by the individual. and completed if the documents by the individual, if they wanted to do documents. But it may or may not involve documents. But as we heard, documentation can take many forms. And so as health professionals, we can contribute to that in the person's notes. And it's only for that time when the person is unable to communicate or make those decisions. So I encourage you to, if you'd like to learn more, because we've really only scratched the surface today, focusing a lot on communication, which was brilliant conversation. There is some free learning that everyone can access from Advanced Care Planning Australia as well. So I encourage you to access that. It's off our website as well. And we do have an international conference that we're supporting in September that I hope we'll see a few friendly faces as well. But yeah, encourage you to go to the Advanced Care Planning Australia website if there's any other questions.
Well, thank you very much, Kylie, and thank you very much, Sam. I certainly learned a lot, and I imagine those that are here too. And it's always a good indicator if people stay on the chat, and they have all stayed. Everyone who joined stayed, so everyone's clearly very interested, and it's been very engaging. So thank you very much, and have a lovely day, everybody.